good morning, everyone. I would like to welcome the panel members and the audience to the July meeting of the Scientific Guidance Panel for Biomonitoring California, more formally known as the California Environmental Contaminant Biomonitoring Program. Thank you all for joining us today. The panel last met on March 20th, 2024. The March meeting included updates on Biomonitoring California program activities, including initial results of a project to assess associations between per and polyfluoroalkyl substances levels in serum in Southern California adults and in drinking water. The panel also heard from guest speakers on challenges and opportunities for biomonitoring for oil and gas exposures. Key discussion topics included examining variables, including drinking water sources that may be influencing the concentrations of PFASs in participants from the California Regional Exposure Study or CARE study, using non-targeted laboratory methods to capture fluorinated compounds that are not detected by the Water Board's targeted methods to help identify PFASs in drinking water, and important considerations when planning a biomonitoring study in communities living near oil and gas facilities, including local exposure sources and identification of chemicals associated with oil and gas extraction activities, potential use of carboxylic metabolites of PAHs to identify petrogenic sources of PAHs compared to pyrogenic sources, and study of population selection and consideration of planned phase-outs of oil and gas facilities in California. The summary and transcript of the meeting is posted on the March meeting page on the program's website at biomonitoring.ca.gov. Following the March meeting, we held a reception to celebrate the 15th anniversary of Biomonitoring California. Program leaders, past and present SGP members, and friends of the program provided brief remarks at the event, highlighting some of the key accomplishments of the program in its first 15 years. I would also like to announce that OEHHA Director Lauren Zeiss retired at the end of June. She had been involved with the Biomonitoring California program since its inception, first as chief of the Reproductive and Cancer Hazard Assessment Branch, where the biomonitoring section is housed, and later in 2016 as OEHHA's director. During her time at OEHHA, she played an integral role in guiding the Biomonitoring California program and supporting the mission and goals of the program and the SGP. We want to thank Lauren for her leadership and guidance and for her service to the people of California. We wish her the very best in her future endeavors. Following Lauren's departure, I will be serving as OEHHA's acting director until a new director is appointed. All right, so first off, wanted to announce that panel member Ulrike Luderer will be acting as the SGP chair for this meeting. And I will now invite panel members to introduce themselves by name and affiliation. We'll start with Jenny Quintana, who is attending remotely. Jenny has been granted a reasonable accommodation to attend this meeting remotely and to not appear on camera for the whole meeting. Her remote attendance will count towards the requirement that a majority of the members shall be physically present at the same teleconference location. Jenny.
Hi, my name is Penelope or Jenny Quintana. I'm a professor of public health in the San Diego State University School of Public Health.
Great, thanks, Jenny. I will now call on Amy Padula, who is also attending remotely.
Hi, my name is Amy Padula. I'm an associate professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco.
Great. I'll now start to my right with Carl Craner.
Carl Craner. Until July, I was a professor of philosophy and faculty member in environmental toxicology. Now I will be known as a professor of the graduate division at UC Riverside because I'm retired officially.
Thanks, Carl. Next, we'll go over to Tom McCone.
I'm Tom McCone. I'm Professor Emeritus of Public Health at the University of California, Berkeley School of Public Health.
Thanks, Tom. Oliver Fine.
My name is Oliver Fien. I am a professor at University of California in Davis in the Genome Center.
And Ulrike.
My name is Ulrike Luderer. I'm a professor in the Department of Environmental and Occupational Health in the School of Public Health at UC Irvine.
Great. Now I will hand this off to Acting Panel Chair Ulrike Luderer, who will provide more details about today's meeting.
Thank you, Dave. So I want to, first of all, just remind panel members to please comply with the usual Bagley-Keene open meeting requirements that all discussions and deliberations of the panel about the subject matters at issue today need to be conducted during the meeting, not on breaks or with individual members of the panel on or offline, including via phone, email, chats, or text messages. Panel members who have not been granted a reasonable accommodation and are attending remotely must appear visible on camera during the open portion of the meeting. If you're unable to keep your camera on during the meeting because it is technologically impracticable, please make an announcement when you turn your camera off. Additionally, if someone older than 18 is in the room with panelists who are attending remotely, you must disclose the presence of that person and their general relationship to you. Can the remote attendees confirm whether anyone over 18 years old is in the room with them? I see head shaking.
No one's in the room with me. Thank
Okay.
you.
Thank
I'll
you.
let you know if that changes.
No
All
one's in
right,
the room either.
thanks. Then I'd like to next announce the panel goals for the meeting. So first, we're going to hear an update on program activities, including findings from the East Bay Diesel Exposure Project, or EBDEP, and laboratory method development for analysis of volatile organic compound, VOC, metabolites in urine. And the panel will also hear from program staff and OEHHA on the monitoring of perfluoroalkyl and polyfluoroalkyl substances, known as PFAS, in human populations and fish species in California, and trends of PFASs and persistent organic pollutants, or POPs, among pregnant Californians later this afternoon. There will be time for questions from the panel and audience after every presentation. And if any of the SGP members wish to speak or ask a question, please raise your hand. I'll call on you at the appropriate time, and then you can ask your question or provide your comment. If online webinar attendees have questions or comments during the question periods after each talk, you can submit them via the Q&A feature of Zoom webinar or by email to biomonitoring@oehha.ca.gov. We won't be using the chat function during this meeting. Please keep your comments brief and focused on the items under discussion. Relevant comments will be read aloud and paraphrased when necessary. If online attendees wish to speak during the public comment periods and discussion sessions, please use the raise hand feature in Zoom webinar, and Rebecca Beloso or Stephanie Jarmo will call on you at the appropriate time. If you're attending in person and wish to comment during the public comment periods and discussion sessions, please come to the front or raise your hand, and I will call on you at the appropriate moment. For the benefit of the transcriber, please clearly identify yourself before providing a comment and write your name and affiliation on the sign-in sheet at the back of the room. So now I'd like to introduce Nerissa Wu. Nerissa Wu is Chief of the Exposure Assessment Section in the Environmental Health Investigations Branch, EHIB, at the California Department of Public Health, and the overall lead for Biomonitoring California. She will provide us an update on current program activities. Nerissa?
My slide set up here. Thank you. Welcome everyone, and congratulations, Carl, on your retirement, and to Lauren as well, if you're listening in. I thought I'd start this update with a reminder of our overall programmatic goals, just as a way of structuring the program update. So as I go through the presentation, I'll be talking both about progress we're making as a program overall, as well as on specific projects. So our program goals and priorities are generally derived from mandates in legislation. We'll regularly take input from this panel and from stakeholders, and also from our respective departments. And the last time we talked about program priorities, which was a couple years ago, we identified these as the primary goals. So surveillance, or measuring exposures in a representative sample of Californians. This is a primary part of our legislation. And surveillance would enable us to assess time trends in the context of public health programs and legislation, and also broader phenomena like climate change, which is one of the priorities that this panel specifically identified. We also want to focus on highly exposed communities and work on mitigating inequities. We want to identify and evaluate strategies for exposure reduction, And we have the long-term goal of expanding the reach and sustainability of the program. So one of the constants of Biomonitoring California is that we have this very complex and challenging mission, but we are a relatively small program. So one of the other things we've talked about over time is the need to really lean into collaborations to really amplify the impact that we can have as a small program by creating meaningful partnerships. So looking at our goals one by one, again, as I said, one of our primary goals is to look at exposures in a representative sample of Californians and to develop representative generalizable data that we can use to look at time trends and the effect of environmental policies and programs. So study design and participant selection are really critical to generalizability of surveillance data. And the gold standard for surveillance is random participant selection and a sufficiently robust participation rate, so you're not introducing bias into your data by over or underrepresenting parts of the population. And this is really a challenge because participation in surveillance, even for very well-established surveillance programs like NHANES, the participation rate has been going down over time. This is something that biomonitoring programs everywhere are dealing with. We do ask a lot of our participants not only to answer questions, but to provide urine and blood samples. So we need to make those participant protocols as acceptable as possible so as not to discourage participation. It's also really important as we develop surveillance to develop a system that's stable. We've learned something from each one of our surveillance efforts and created valuable data, but it is a challenge to compare data across studies because the study design changes. So our goal is to create a surveillance system that gives us a stable, ongoing source of data that we can use to understand population exposures and trends. So our primary surveillance efforts to date have been the California Regional Exposure or CARE study and STEPS, studying trends in exposure in prenatal samples, which is currently in progress. And we're starting to plan for what surveillance will look like after STEPS. So we've presented here the data generated by CARE. We've summary statistics, as well as Toki Filman's work to look at associations between drinking water and serum PFAS levels in CARE participants. And we still have this rich data set with metals and other analytes, exposure questionnaires, and other information. So we have a lot of analyses in the work, which you'll hear about over time. And in STEPS, the laboratory analysis for STEPS has started. We have focused first on Orange County samples, about half of which have been analyzed so far. And we're hoping that in the next year, we'll be able to present that time trend data for Orange County. So the plan for sample collection for STEPS is to continue through 2027, and the lab work will continue subsequently. And STEPS is going to give us really informative data on PFAS levels in Californians. We have a number of collaborations being developed to look at STEPS to examine exposure sources, to look at newborn outcomes, and potentially to understand the unmeasured PFAS fraction. But using samples for prenatal samples, as STEPS does, has a number of advantages and disadvantages. The samples are easy to obtain. We can do random selection of sampling, which is all great, but there are limits on what we can measure. We only have serum, and it's a fairly small volume. And we don't have exposure information from participants, although we do have residential address and can do linkages to drinking water source and other exposure sources. So as I said, we'll continue using STEPS for the foreseeable future, but our goal for the next surveillance effort is that we'll have a combination of all the best attributes of our prior surveillance efforts: randomized population-based participant selection, collection of urine, blood, and serum, and sufficient volume for each of those, and the ability to collect exposure data through participant questionnaires. So our plan right now is our hope to work with an established surveillance program, which would give us a frame for random sampling. And that gives us the ability to weight the data and come up with generalizable population data. Working with an established surveillance program also enables us to link to data that they're collecting, which really amplifies our ability to do data analysis. So we still have a lot of details to work out with regard to how we'll interface with an existing surveillance project. And of course, there's always a challenge of collecting samples in field work. So there are a lot of details to come, which is why it's not scheduled to start up before 2028. But as we develop more details, we'll bring those to this panel and solicit input. The second goal I wanted to highlight is identification of highly exposed communities and working towards equity. So through our AB 617 projects and the Asian Pacific Islander Community Exposures, or ACE projects, we've been focusing on specific demographics or geographic communities and the unique exposures that they're facing. You'll hear about ACE and the East Bay Diesel Project later today, so I'm just going to give a brief update on the other 3 projects. For Biosphere, biomonitoring component of the San Joaquin Valley Pollution and Health Environmental Research Study, we have data on the urinary biomarkers of response, and staff are getting ready to return those results to participants. Staff are also working to evaluate air monitoring and questionnaire data, and we have just received the PAH and VOC data. Staff are just starting to look at that. For Fresco Mujeres, the farm worker women and respiratory exposure to smoke from swamp cooler air, similarly, staff are looking at air monitoring and questionnaire data. The urine samples are at the lab for analysis right now, and there is a community meeting being planned for August 2024 to talk about air monitoring results. Last time we met, we reported on SAPEP, the Stockton Air Pollution Exposure Project, and at the time there's some question about the 2 NAP results. It was unclear if it might be related to naphthalene or perhaps carbol exposure. The lab was able to do some additional analyses to determine that the exposure is likely not carbol, but there's still this outstanding question of why the results were elevated. The results have been returned to participants, and a community meeting to discuss results was held in April, but we're continuing to work on those results and we'll report back as we have other findings. On the goal of identifying exposure sources for all of our studies, beyond trying to demonstrate and measure chemical exposures, a primary goal is to determine how people are being exposed. And this is important so that we can work on reducing exposures on the individual level. You know, what can I do today to reduce my exposures? We have the community level, and we also have the policy level. Where should we be focusing regulatory or legislative efforts? So we've always collected questionnaire data and residential address, but the program now has more capacity to conduct the epidemiology needed to identify exposure sources. You heard last month about the association between drinking water and serum PFHXS levels. Today, you're going to hear about consumption of fish and PFAS levels. And in all of our AB 617 work, we have air monitoring data to help us interpret and understand exposures. Biomonitoring is really multidisciplinary and complex. And so one of the ways we've really been expanding our reach and impact is through our partnerships with community organizations, academic researchers, and other state programs, synergistically working together on our mutual goals. And this increased focus on reaching outward has had the effect in the last year or so that our program is getting more notice. We're getting lots of data requests, which is great. Thank you for sending us your colleagues and students. And there's really an increase in the recognition of how valuable our data is. And the hope is that over time, this will translate into more support for the program and eventually allow us to cover even more ground. The staff is super productive, but we're always aware of the chemicals that we're not measuring, all the things that we are not able to study. And as part of expanding the reach of our program, the labs continue to expand the number of chemical panels that we can run. So PAH and VOC metabolite assays are now ready for use, and you'll hear about the VOC metabolite method this morning. And they're continuing to develop methods for PAHs and cyclosiloxanes in serum, as well as non-targeted analysis. So we're making really good progress on all of our programmatic goals. And in addition to that overview, I want to highlight a few other program activities, including outreach and communication. We've described the CARE study report in previous meetings. Both English and Spanish versions have been posted on our website. On April 18th, we held an open webinar. We invited CARE participants, community partners, local health jurisdictions, and researchers, and other biomonitoring programs. The webinar was presented in English with real-time Spanish translation, and we had almost 200 participants in the webinar, which was great. Lots of very active dialogue, lots of questions back and forth, including a discussion through email, which continued for some time with some participants, which really demonstrated an engagement and an interest in biomonitoring, both at an individual and a community level. We also had a public event to discuss the results of the Stockton Air Pollution Exposure Project. Flyers went out to parents of the students at the school where the study was conducted, the All Saints Academy of Stockton, participant families, community partners, community members, including teachers from the school, were at the meeting. Again, it was online, available in English and Spanish through real-time translation. And there was a good discussion about local exposure sources, exposures in the home, and through consumer products. And we got the feedback that people really appreciated the data that was generated and the air filtration that was provided to the school. Just finishing up with some quick lab updates. EHL is continuing to work on CARE LA samples so that we will have population level data for speciated arsenic and phenols. We actually just got the speciated arsenic data. We should have phenols later this summer. So we'll be working on summary statistics and getting results back to participants. The lab's also been busy measuring specific gravity and creatinine to do dilution correction for 194 biosphere samples. We've just about finished up with 155 Fresca samples, and now they're working on PAH analyses for Fresca mujeres. EHL has also been completing analysis of our intra-program pilot study samples, and results are in the queue ready to be reviewed. And over in ECL, focusing on STEPS, we have a queue of over 1,000 samples waiting for PFAS analyses. As I mentioned, over half of the Orange County samples have been analyzed. So lots of progress there. And just additional news, EHLB has been able to add some new machines to the lab, which will enable some more efficient processing of our samples. So just another way to look at the team's work over time and think about how the program projects into the future is to look at the various activities related to different stages of study design and implementation. So for any given study, we go from planning to field work and sample collection. We have lab analysis and reporting. We create summary statistics and results return before we dive deeper into the data and look at exposure sources, and finally communicating them out to various audiences. So in order to keep the program moving efficiently, at any given time, we have to have multiple studies at all different phases of this continuum. So we are actively collecting samples in the field with STEPS. And at the same time, we do have samples from STEPS, Biosphere, Fresca, and CARE at the lab. Our epidemiologists are working on the IPP, CARE, Biosphere, and Fresca data, getting that back to participants and having it summarized for publication. While they're also doing more detailed analysis of CARE, ACE, EBDEP, MAMAs, and SAPEP data. Our communications team is working to distribute the findings for FREEZE, ACE, CARE, and SAPEP, while also working on chemical fact sheets and more general public-facing material. And while all of this is going on, we're planning for the future by working on future protocols for community-based studies and for surveillance. And this is what keeps our program moving forward and looking to the future. Of course, our labs are working on new analytical methods that we can use in all of those new studies. So this is the team that gets all of this work done. Just have 2 staff changes to report. Joginder Dhaliwal, who's been at ECL for some years, has left the program. So thank you, Joginder, for all of your work. And Dr. Unlu Song, who's the new chief of the inorganic unit in EHLB. Happy to have you join us. Welcome. And if you are interested in joining the biomonitoring team, please visit this website, and we'll have some job openings posted during the break as well. And with that, I will not show you extra slides. I will take questions.
Thank you very much, Nerissa, for that overview. We'll start with questions or more clarifying questions from panel members, and then we'll have time for open discussion after that. Tom?
Thank you. It's always amazing how much is going on. I mean, especially since we went through a couple of years where we couldn't do very much because of COVID, but an impressive list of accomplishments. In that last slide about the various stages of studies, the planning phase. So early in I think your second slide or one of the early slides, one of the goals that was added was to do something on tracking how climate change affects exposure, or what metrics we could be looking at for that. Is that in some sort of planning phase, or is there a separate program to look at that, or is that still like before planning in its
Well, we don't have something explicitly focused on climate change right now. I think there's recognition that in order to really do time trend, we need to have an established surveillance system that can have an unbiased generalizable population sample. So I think getting that set up will help serve this overall goal of looking at how air pollutants, for example, are changing over time.
Oliver?
Yeah, thank you. I'm equally impressed. But I'm also equally interested in the future because that's, of course, something we can change or think about. So I think I had two questions. One is if people are staying more and more indoors, what are, the plans to monitor more the indoor activities? As we see, just picking up on climate change, it's getting hotter and hotter. So people will stay more indoors. So that's the first question. And the second question I had is deeper data dive. What are you planning there?
Don't you want to wait and find out when we present it? Well, for the indoor air pollution, that's a good point, that our environment is changing overall, whether it's related to climate change or other things. I think some of the work being done with the AB 617 communities with air filtration and what people can do to impact their indoor environment is a great step towards that. I think we're also learning a lot about how those questionnaires should be developed in order to capture the relevant information that we need to know to interpret that. And in addition, the kinds of environmental sampling that we need to do to collect that. So maybe when we're talking about AB 617, somebody could elucidate on that. In terms of the deeper data dive, I mean, beyond the summary statistics, you've seen a lot of modeling work being done to connect, for example, drinking water with PFH excess levels. That involves a lot of geographic analyses. So having a residential address and looking at exposure sources, which might be drinking water source or industrial or highways. There's a lot of, I think we have a lot of hopes for the CARE data with that, as well as STEPS, since we do have the residential addresses, but also using our exposure questionnaires. And they're tricky because you need to ask the right questions and get the right distribution of answers in order to be able to find something in your model. But there is a lot of focus on using that data going forward, as well as the environmental data to discern what the exposure sources are.
I do have a question, and again, looking at the various studies in progress is really quite impressive, and all the work that's been going on in this program and the studies that are coming out, the results. My question was, you mentioned that in the future, working with established surveillance programs was one goal of the program, and I'm wondering if you have any surveillance programs in mind that you're thinking about working with.
We have talked to a couple, one being the statewide California Health Information Survey, and the other is maternal and infant health assessment. We're not at a point of agreement. We haven't negotiated a working relationship with them yet, but we are exploring the possibility of working with either of those.
Great, thank you. And I see two raised hands. Jenny, would you like to go first, and then Amy?
I think Amy was first, actually, temporally.
Okay, I saw your hand first, sorry.
I'll start if you want. Either way is fine though. I guess I just had a quick question about the PAHs that are being measured. It looked like from the slides that they'll all be done in urine. I was wondering if that was indeed true, or if any will be tested in blood samples in the future.
Currently, the method we have for PAHs is for urinary metabolites. DTSC staff is working on a PAH parent compound in serum. I don't know if Jun-Soo is here. I don't know if you want to add to that, Jun-Soo.
That's all. We are making good progress.
We can't hear you up here.
Yeah. We are working on it. Dr. Amber Kramer and Amy, the APHL fellow, are working on the PAHs in blood. So we just reviewed the data yesterday. It looks good. They're making good progress. That's all I have.
Jenny?
Hi, can we go back to this slide with the vulnerable communities? I think it was 1 or 2 slides back. Maybe a lot of slides back. I'm sorry. Yeah, right here. I guess one kind of really general thing to think about for the future, I think, is how is California different from the rest of the country? Like what monitoring would it be especially important for us to do that would give information beyond what the NHANES-based CDC analysis is doing? So I think it's worth some thinking about if we're focusing on specific communities to really think about what is different here in California to really get the most bang for our buck in a sense. And I know we've discussed this before, but I think some things that make us different are high levels of immigrant communities, a lot of refugees community. I know San Diego, where I live, is one of the centers for refugees for various different areas. So I think some of those, and they come with perhaps a higher body burden already than they're already at, that they might be adding to, so they might be especially at risk, for example. So I just think we should maybe discuss as we move forward, you know, how best to focus on what is either unique or more prevalent in California in terms of exposures or populations. Thank you.
Thanks for that comment. Those are really great points. I think with some of the work that Kelly's going to present this afternoon, there's definitely concern about populations, including immigrant populations, that are more impacted by because of their diet and because of reliance on subsistence fishing, potentially. Central Valley work is concerned. There's agriculture and a particular geographic structure that makes that area particularly vulnerable. But the other thing that we have in our studies that we cannot get from NHANES is the geographic analyses, proximity to sources, but also some of this behavioral work. So in addition to studying exposures that might not be studied in NHANES, I think the ability to really tease out some of those distinctions is important.
Thank you.
Ulrike, this is Stephanie Jarmal. We have one attendee with their hand up and then a comment in the chat. So I'll let Ken unmute himself and speak.
Yeah, good morning, everyone. This is Ken Sutu from Citizen Air Monitoring Network in Vallejo, California. I saw there's one item which is looking for community to participate. Currently, Citizen Air Monitoring Network has a grant from CARB doing black carbon monitoring in our city. And also at the same time, we work with UC Davis Air Quality Research Center on PN speciation. And I think many people in my community are interested in biomonitoring, especially including Vallejo and several surrounding city, which basically we are in a refinery community. So my question is there any possibility to join this this program, and what is the process? Thank you very much.
Thanks for your question, Ken. I'm actually going to defer this to Stephanie because this is more of an AB 617 question.
Hi, everyone. Yeah, thanks for that question, Ken. And I think it's kind of similar to the one we got in the chat too. But so there's a lot of factors that we consider when choosing to go into a community to conduct a biomonitoring study, but we are always open to having conversations with different community groups, concerned community members about potential collaboration opportunities. And so perhaps we could schedule a meeting after the SGP to talk about your particular situation and what you would hope to achieve with the biomonitoring study.
Okay, thank you very much.
Stephanie, you said there was another question in the chat, but did you kind of just answer that?
Well, I'll read it aloud anyways.
Okay.
How do you identify your community-based studies? Do community members reach out to you directly with concerns, or does your team identify possible exposure hotspots from previously collected data? Well, I can talk a bit about the AB 617 study. So it's a bit of a combination. as I was just saying with Ken, there's a lot of factors you have to take into account, such as what is the exposure of concern, are there biomonitoring methods to identify, if it was metals or, we often look at pHs, VOCs, but if there's something else that perhaps we don't have the methods for, we'd have to consider that. Also geographic location, what are the exposure sources nearby? And if it's something that we can potentially look at. And I think we are trying to learn from our past studies, just speaking with our communities, and we've conducted a lot of listening sessions with different communities to learn about their exposure concerns and what they hope to see from the program. So we're trying to work off of that information and identify both community collaborators and academic collaborators that would really help build a robust study. Hopefully that's it. And Nerissa, if you want to add?
Yeah, I wanted to add on that. For example, the Asian Pacific Islander Community Exposures Project was built because we had seen in the data from the BEST and from other studies that Asians had elevated PFAS levels, but it wasn't well understood why that might be and whether there's variability due to other factors in the Asian community. So that's how the Asian Pacific Islander Community Study was born. And we have learned much more about the exposure process. And also, as you'll hear this afternoon, both in ACE and MAMAs, we've learned much more about subpopulations in the Asian community.
Great, thank you. We have some time now for open discussion among the panel members. Anyone want to start? Tom?
All right, seems like I always start. I'm in a hurry. I'd like to go back, and at least some of us have some interest in the climate, how we use biomonitoring with regard to climate change. And I'm thinking that we might want to schedule a period of discussion at a future meeting about what that might entail. I think we all have some ideas, and they're probably a little different. And maybe we should see where we converge and what's possible. Like, should we be looking at, the issue of, do people spend more time indoors, and would we see that in biomonitoring? But there's also questions about fire, wildfire exposures going up, and what would that look at like? Could we find that? Could we see the trends? If there's a drought and it affects the availability of water, that could increase water pollutants. There's a number, and even quite relevant to today, where I think it's going to be 107 here. I'm glad we're inside. Are there ways to see markers of heat stress? And that would be a bit advanced, but maybe that's something we might want to talk about, because it's very realistic that California is going to be seeing more of these long-term heat wave events, so is the rest of the country. So again, these are just some ideas, and I don't think we can resolve, it's not really appropriate today, but if we could carve out a short period of time about what would we do for climate in a biomonitoring context, and what could we do short term, what could we do long term, what would this take, just so the panel can engage with the staff on it.
Oliver, did you have a question? No, okay. I just did have one question, kind of going back to, availability of samples that are more population representative. And I know at several meetings, we've talked about developing methods for measuring different analytes in the newborn blood spots. And I was wondering if there's is that still ongoing or not?
We are not working on newborn blood spots right now. APHL has actually come out with a statement against using newborn blood spots for biomonitoring, in part because of the technical difficulties and the representation of the blood spot compared to a venal blood sample, but also because of participant rights. Not all states have the same kind of consent process that the California Newborn Screening Program has, and that's created some issues with researchers in other states. So at this point, we have not continued with that. The other thing I guess I would say about newborn blood spots is They are you could probably get around this through using part of the card, the newborn card, as a blank, but they are not really stored in a way that is protective from other environmental contaminants. So I do have concerns about what the blood spot might represent also.
Thank you. I think, are there any other public comments for this part of the discussion? I just wanted to check with Stephanie and Rebecca about that.
Nothing online. I can see Amy had her hand up though. I don't know.
Yes, I was just about to say that. Yes. Amy?
Oh, I just wanted to follow up. I agree with the issues with the blood spots, but I was also curious with respect to available samples, whether the maternal samples that are taken for screening tests during pregnancy may be more suitable for biomonitoring, and whether there's any plan to evaluate those.
We are using samples from prenatal screening, second trimester, that we get from Biobank, both from the MAMA study, which you'll hear about this afternoon from Dina Dabraka, and also STEPS. That's all based on Biobank samples. So it's a great resource. It's amazing that we can use the prenatal screening program as a sampling frame and really get a population sample. So we will be able to do some time trend work looking at PFASs over time in several different counties, but they are only banked for 7 different counties, and it is a very small volume, and it's only serum. So as I said, we're going to have amazing data from STEPS, and there's a lot we can do with that data, but there are all these other chemicals that we would like to look at. Particularly, we're missing all the whole blood and urinary samples, and it has been a challenge to think about how to use that very small volume in the best way. You know, it's precious to us. So we're thinking about pooling, we're thinking about other ways we can leverage this resource for as much data as we can, but those challenges remain. The other thing is that the prenatal screening program is changing. It has always been, or for the last 10 years or so, has been covering about 70% of pregnant women or pregnant Californians. And at this point, that demographic is changing. They have introduced a new screening modality for first trimester, which is outside of the state program. So the sampling frame itself is going to change. It's only a year or 2 old at this point. So the representativeness is something that we're really paying attention to.
All right. Just turning to see if there are any additional comments or questions from the panel, and not seeing any, then thank you very much, Nerissa, for that great presentation. And I would like to introduce our next speaker, Aalekhya Reddam, who's a research scientist in the Safer Alternatives Assessment and Biomonitoring section at OEHHA, and she's going to give a presentation on additional findings from the East Bay Diesel Exposure Project's EBDEP. Aalekhya.
Thank you. Good morning, everyone. Today, I will be giving an update on the East Bay Diesel Exposure Project and all the work that's been done since you last heard about the results from the study. Before I jump into the presentation, I would specifically like to thank Dan Sultana and Kelsey Ranjabar for all the analysis they've done for this project. Thank you, guys. So there were a few main project goals for EBDEP. The first one was to assess exposures to diesel exhaust in impacted communities of the East Bay. We also wanted to evaluate predictors of diesel exhaust exposure using predictors, for example, as traffic density. We wanted to compare daily measurements of exposure biomarkers in parent-child pairs to increase our understanding of exposure patterns, specifically between communities, within communities, over time, and also within families. We also wanted to evaluate the effectiveness of diesel regulations in California and engage with community and policymakers about study results. Our study population consisted of 40 parent-child pairs. We collected environmental and biological samples and questionnaire and activity data between January 2018 and February 2019. And as you can see in the map over here, our participants were recruited from various cities along the East Bay. We had 2 sampling rounds in our study to help evaluate exposures over time. In round 1, we collected air, dust, and urine samples, and in round 2, we collected just air and urine samples. Our air samples were collected over the span of 4 days, and our dust samples were collected from a vacuum bag or canister, and when that wasn't available, we collected a sweeping sample. From our 40 families, 25 families gave 1 urine sample per participant per round, and 15 families gave 4 urine samples per participant per round so that we could evaluate within variability and between subject variability. As I mentioned before, one of our main goals in EBDEP was to assess exposure to diesel exhaust. 1-nitropyrene, or 1-NP, as I'll be referring to during the presentation, is formed during the combustion by nitration of polycyclic aromatic hydrocarbon, or PAH, within the diesel engines. It is the most abundant particle-associated nitro PAH in diesel exhaust and is thought to be more specific than other PAHs when indicating exposure to diesel exhaust. 6-hydroxy-1-nitropyrene, or 6-OHNP, and 8-hydroxy-1-nitropyrene, or 8-OHNP, are urinary metabolites are 2 of the urinary metabolites of 1-NP and are thought to be used as exposure biomarkers to diesel exhaust. As I mentioned before, we collected urine samples, air samples, and dust samples, and most of these samples were analyzed by Chris Simpson's lab at the University of Washington, but the black carbon was analyzed by the Lawrence lab at UC Berkeley. In our urine samples, we measured 1-NP metabolites, 6-OHNP and 8-OHNP, one of the pyrene metabolites, 1-hydroxypyrene, as well as metabolites of volatile organic compounds. In our air and dust samples, we measured 1-NP, 2-nitropyrene or 2-NP, 2-nitrofluorantene, and additionally measured black carbon in our air samples. The preliminary results from EBDEP were presented at the November 2019 SGP meeting, and they were also finalized and published last year. This paper included a description of the EBDEP project, demographics of our participants, and also correlation and summaries of 1-NP in air and dust and 1-NP metabolites. The major conclusions were that at least one 1-NP metabolite was present in 97 participants of 90% of our urine samples. We also saw that urinary 1-NP metabolite levels were generally higher in fall and winter months compared to our spring and summer months. Urinary 6-OHNP was significantly higher in parents compared to children, and the same was true for 8-OHNP as well, but it wasn't significant. We see that children urinary 8-OHNP were weakly correlated with 1-NP in air and dust, and air and dust 1-NP levels were higher in homes with high cal and virus screen diesel particulate matter score, and these were our main conclusions. All the EBDEP demographic results were discussed in the November 2019 SGP meeting and also presented in the published paper. But just as a quick recap, for the parents, 95% of the participants were female and 5% were male. Whereas in our children, our distribution was a little more even, with 52.5% being female and 47.5% as male. The average age of our parents was 36.6 years old, and our children were quite young, with the average age being 4.7 years old. Lastly, in our parents, 5% were American Indian / Alaskan Native or Native Hawaiian / other Pacific Islander. 5% were Asian, 20% were Black / African American, 40% were Hispanic / Latino, 35% were white, and 2.5% preferred not to say. And the ethnic distribution of our children very similar to those of our parents. So with that, we had 2 main aims with our additional analysis that we completed. One was to use 1-NP in air, dust, and its metabolites in urine to examine geospatial predictors of diesel exposure. And our second aim was to examine predictors of VOC metabolites. As we didn't have a lot of participants who were exposed to diesel occupationally, we used geospatial predictors. Previous research has shown that spatial characteristics such as traffic volume, road density, and population density have been useful in predicting traffic-related air pollution, so we thought it could potentially be used to predict diesel exposure. ArcGIS was used to create individual spatial predictor variables for each household for multiple buffer zones. So using our Oakland OEHHA office as a surrogate for our participants' residence, we can see the 5 different buffer zones that were evaluated in the analysis. So we had 150, 350 meters, 500 meters, 1,000 meters, and 2,000 meters. Within these different buffer zones, we use publicly available data, mostly from Caltrans, to generate a suite of geospatial predictors for each individual participant. For example, you can see in this map that the blue dots are bus stops, and all the highlighted lines, which are blue, gray, and yellow, I'm not sure if you can see it very clearly in the room, but those are major roads. We compiled all this data for each buffer zone for each participant in relation to the participant. In addition to major roads and bus stops, we also calculated distances to different types of major roads, the length of bus routes and other types of roads, different types of traffic densities, as well as counts of permitted sources. An example of these permitted sources are gas stations or hospitals or generators for stores, approved generators for stores. We then use this data to examine associations with geospatial predictors and 1NP in air and dust and its metabolites. All the concentrations were log transformed and the urinary concentrations were adjusted for specific gravity. As most households had only one dust collection, we used linear regression models for associations between 1NP in dust and geospatial predictors. For the few households that had more than one measure, we averaged the dust concentrations. We use mixed effect models for associations with 1NP in air and 1NP in metabolites to account for their multiple measures. And the models with the metabolites were adjusted for relevant covariates. So in adults, the models with the metabolites were adjusted for season, income, candle use, sweep frequency, types of food consumption, presence of gas and dryer and washer in adults. And in children, the models were adjusted for season. We chose these covariates based on their association with the metabolites and selected ones that we thought were most relevant for the model. So all the data from the results are presented in this table. Each check mark represents a significant association, and all the associations were positive. So for example, in the first row, we see that all traffic densities at each of the 5 buffer zones were significantly positively associated with dust. So there's a lot of data here, but I think our main takeaway from this table is that 1NP in house dust had more significant associations with spatial predictor variables than air concentrations of 1NP. Dust usually represents a more stable matrix than air and therefore may be more indicative of chronic human exposure. And moreover, geospatial predictors that are further away are thought to contribute more to ambient exposure versus closer radii are thought to contribute more to personal exposure. We did have one participant that had very high concentrations of dust. I think they were orders of magnitude higher than the next one. And in sensitivity analysis, when we remove this participant, we lose some of these significant associations, but the direction is still the same. Our 1NP metabolites were only significantly associated with the length of major roads and only in our adult participants. 8OHNP was significantly associated with length of major road at 150, 350, 500, and 1,000 meter radius, and 6OHNP was only significantly associated in the 1,000 meter radius. When we ran the analyses with the metabolites summed, we see a similar direction, which is positively associated, but we do lose some of the significant associations as well. Now we move on to our second aim, which was to examine predictors of VOC metabolites. These results were actually just returned to our participants earlier this year, so this is the first time that these results are being presented. Volatile organic compounds, or VOCs, are a class of compounds that are carbon-containing chemicals, which vaporize and can enter the body through normal breathing. And as we can see in this image, there are several indoor and outdoor sources of VOCs. In EBDEP, 13 VOCs were specifically selected based on their associations with diesel exposure, and we wanted to examine their association with predictors of traffic-related air pollution, once again using our geospatial predictors, and also with other participant characteristics and indoor sources using our information from the questionnaires. As a quick note, the measuring of the VOC metabolites was added a little further on in our project, and therefore, while we have some questions that might be relevant to the concentrations of VOC metabolites, we weren't able to account for all potential predictors. So as I mentioned before, we had 13 VOC metabolites, and these were analyzed in the urine by the CDC. And as these were run by the CDC, we have a few more VOC metabolites than our CDPH and Biomonitoring studies, which are run by UCSF. The next presentation is actually by our environmental health lab, and they'll talk about their progress with their VOC method, which we hope to incorporate in our future studies, which is really exciting. From this table, we see that other than one of the benzenes metabolite PMA, the detection frequencies for all of the metabolites were measured above 70%. And then other than acrylate nitriles metabolites, CYMA, all levels were higher in children compared to parents. We initially adjusted for metabolite concentrations with creatinine so that we could compare our concentrations with NHANES. However, for our analyses, we adjusted for specific gravity and log transformed the concentrations. Similar to the 1NP analysis, we used mixed effect models to account for multiple samples. We initially ran the associations with participant characteristics and relevant predictors, and then used the significant associations and ones that we thought were important in the model to look in our models with the geospatial predictors. For our adults, with the geospatial predictor models, we adjusted for season, income, candle use, and presence of gas dryers, and children adjusted for only season. Furthermore, when running the models for the participant cities, to ensure a more even distribution, we binned the participants into Richmond, Oakland, and all other cities were binned into another category, another city. And this is again, just to ensure a more even distribution of participants. When examining the correlation of the VOCs, all of them were positively correlated with each other. However, only a few were very strongly correlated with each other. And we define this as a Spearman correlation coefficient of more than 0.6. We see that ethylbenzene and styrene metabolites, PHGA and MADA, were strongly correlated with each other, which could be attributed to their common parent compound. We see that isoprene, acrolein nitrile, and 1,3-butadiene metabolites were strongly correlated with each other, and they're often used in conjunction with each other for consumer products to make rubber, so that could possibly be the reason for the strong correlation. We also see the acrolein nitrile metabolite and one of the xylene metabolites, 2-MHA, were strongly correlated with each other, which could also suggest common use patterns. And then acrolein metabolites, CEMA and HPMA, were strongly correlated with each other, which again can be potentially attributed to their common parent compound, acrolein. When we then compared our creatinine adjusted concentrations of the VOC metabolites to levels from NHANES, we compared our parent levels to those of adults in NHANES and our children levels to those the closest NHANES reference group, which was between 3 to 5 years old. And just as a reminder, our mean age for our children was 4.7 years old. So to focus a little bit more, the metabolites that were higher in our EBDEP population compared to NHANES are highlighted. Moreover, there were 5 metabolites where the 95% confidence intervals from the 2 populations don't overlap, and we counted this as significant. So in our adult populations, we saw higher levels of the metabolites of acrolein, benzene, ethylbenzene/styrene, and propylene oxide in our EBDEP population compared to NHANES, and the isoprene metabolite was significantly higher in our child populations compared to the reference NHANES population of 3 to 5 years old. There are several potential sources of the VOCs for which we saw higher urinary biomarker levels in our EBDEP population, and a few of them are highlighted here in this table. 4 out of the 5 VOCs shown here are products of combustion fuels or combustion of automobile exhaust, but several of them are also used in the creation of plastics, rubbers, and are detected in our consumer products. When looking at associations between VOC metabolites and demographics, we see that participants with the lowest income had higher concentration of total VOC metabolites and higher concentration of xylene metabolites compared to participants in the higher income category. And then when looking at city of residence, we see that participants who lived in Oakland had higher concentrations of total VOC metabolites compared to Richmond. And just as a reminder, our participants were binned into Oakland, Richmond, and other. And lastly, after adjusting for city of residence, our Black participants had higher concentrations of xylene metabolites and benzene metabolites compared to our white participants. We did adjust for city in this model specifically because all our Black participants lived in Oakland, and we wanted to ensure that the association results weren't as a result of city of residence. We also looked at associations between VOC metabolites and potential predictors based on the questionnaire data. We see that candle use in the past 3 days was associated with higher total VOC metabolites in adults and children, and higher benzene and isoprene metabolites in adults. We see that gas stove use in the past 3 days was associated with higher ethylbenzene/styrene metabolite and benzene metabolite in children. And gas washer and gas dryer in the house was associated with higher ethylbenzene metabolite in children, and gas dryer only was associated with higher total VOC metabolites in adults. Lastly, we examined associations with the same geospatial predictors that we mentioned before with the total VOC metabolites and found that traffic density was associated with higher total VOC metabolites in adults. And then we also see a similar trend that we saw with the 1NP metabolites, where the length of major road was associated with total VOC concentration at 150, 350, and 500 meter radius in adults and 150 meter radius in children. So with all of that, our conclusions from these additional analysis is that 1NP in air and dust was significantly associated with several geospatial predictors of traffic. And we see that 1NP metabolites in urine was positively associated with length of major roads. For our VOC metabolites, we see that they were significantly associated with demographic variables, with gas appliances and candle use, as well as traffic density and length of major roads. I'd like to thank the EBDEP parents and families for participating in the study and our collaborators at the West Oakland Environmental Indicators Project. at the University of Washington, Lawrence Berkeley Lab, as well as the CDC and all the Biomonitoring California staff. Thank you.
Thank you very much for that really great overview and interesting presentation. We have time now to start with for clarifying questions. Any from panel members to start with? Oliver?
Yeah, thank you. This is a truly interesting study, but maybe underpowered. So, you know, I mean, I'm not a statistical expert, but I use statistics all the time, including all the models that you've talked about. And, you know, I'm a little concerned about the numbers here. You also said, like, you know, numbers are a little different when you remove an outlier. Well, that's the point. We don't want to remove outliers because we want to know really the distribution across a population. And if you then do multiple adjustments, you know, things get weaker and weaker. So in principle, there's two things. One is significance and the other one is effect size. What can you tell us about effect sizes?
Yeah, and I think something to point out also is even though our sample size was 40 people, we did have multiple measures. So I think altogether we had around 300 samples to work with. So I think we did have a relatively higher sample size. And sorry, could you repeat your question about the effect size, please?
Yeah, so that, you know, it's not just the ability to say something is significant, but also in terms of meaningful. You know, instead of meaningful statistics, people say effect size. You know, so is anything doubled? Is anything, you know, I mean, what are we talking about here?
Yeah, of course. So I think for the models where we use the mixed effect models, we did see maybe a 10 to 20%, and I'm generalizing here, increase effect size, if that, yeah, the beta estimate is what we saw.
If you could go back to the slide on predictors of VOCs. I was curious, it says gas stove, but did you consider gas oven use?
Yeah.
I mean, when you say gas stove and oven?
This was just based on the questionnaires. And as I mentioned before, it was very much tagged on to the end of the study. So I think we didn't go as specific as we would have liked for the VOC metabolites. I think that there wasn't a specific question about gas oven that I know of, but if anyone else knows otherwise, please let me know.
Actually, what's a gas washer?
I think it's probably a washer that uses gas versus electricity.
I've never seen a gas washer, but I mean, well, and this is the question of water heating would be a key issue, especially if they have the water heater is indoors. Yes. And a lot of them, especially in smaller residences and communities that aren't as wealthy, the water heater might actually be just right in the middle of the house somewhere.
Yeah, absolutely.
Okay.
Thank you.
Carl?
It's a quick question because I'm puzzled. Do lots of people use candles anymore? You're testing for candle exhaust.
I actually was using a candle when I ran this analysis. So I don't know, I guess, I mean, the distribution, there were a good amount of people that use candles. And also our question was candle and incense use. So I'm wondering if more people use incense versus candles, but there were a good number of people that use candle or answered yes to this question.
Thank you.
I have a clarifying question too, and that is, I think the the cooking, the gas cooking is very interesting and obviously an important exposure source inside. Did you ask any questions about sort of mitigation measures, like whether they had a vent hood, and whether it vented to the outside, and did that make a difference?
Yeah, no, we did have those questions. We had questions about, and also how often the vent was cleaned, and if it was cleaned based on a follow-up questionnaire, and they didn't make any difference. Yeah, and also I don't think there was a great distribution of variables. So I think that could have also played a role in it. Maybe if you had a larger sample size with more people that were in each of those categories, we would have seen more of an effect. Thank you.
This is Stephanie. I do want to maybe let Swen also, who was heavily involved with the EBDEP today. I don't know if you wanted to add to that, Swen.
Yes, thank you, Stephanie. Swen Kaufman from Biomonitoring California. And I just wanted to clarify some of these questions that we asked. Some of these were the questionnaire and some were based on a home walkthrough that we did. But yes, we did ask about candle use and had The question was candle, votive, incense, and sage burning, all in one question. So we did have people responding affirmatively to that. And then for gas stove, the question was specifically about stove. We didn't say oven. I think it was implied, but yes, the wording was specifically whether or not you had a gas stove. And we did ask about mitigation, like, you know, a hood range, whether or not it vented to the outside and how often that was used when they cooked. And then for the gas, washer and dry, we did ask about a dryer. I'm just flipping through the question. We asked specifically for a dryer and not a washer for that one. And then also about the presence of a gas water heater, whether or not it was located inside the house.
Thank you, Swen.
Thank you. I see Jenny, you have a question?
Hi, thank you for the study, very important. I just had a quick question. I looked briefly at the article. I think you had a question about how many people smoked inside the home, and maybe one person did. And but I didn't see questions about exposure outside the home. And I'm just wondering, not so much for 1-nitropyrene, but or some of the other things like acrolein and tobacco smoke. And I'm just wondering if you measured cotinine in the urine.
I don't think we measured cotinine in the urine. Yeah, we did not. But I think moving forward, that would be a very important thing to measure. Thank you.
Okay, I'd like to.
Sorry, this is
Yeah, I was
Stephanie.
going to ask if there were any questions from the public.
Not yet, but I did want to mention that actually all of our current studies say PET biopsy or fresco. We did measure cotinine in the urine. And so we have incorporated it into our current studies.
Thank you.
Okay, great. Thank you. We have time now for kind of general discussion about this presentation and related topics. Anyone on the panel like to start? Oliver?
Yes, so going back to this question on statistical power, I was a bit concerned that there were only 5% of the participants were male. And I think this sexual disparity is something that is concerning because people might have different habits, possibly. So obviously you can't go back in time, but if maybe for the future, we have to really make sure that the genders are equally distributed.
Thank you.
There are comments from panel members? Tom?
I'm looking for the slide where it mentioned the first study was consistent with Callan virus screen. I was just curious about that. That's actually a very interesting. It was just one little line there. Oh, there it is. Air and dust were higher in homes with high Callan virus. So that means Callan virus screen is useful as a starting point to find out where you're looking. And I guess the bigger question, you know, for other things we're looking at is, have we missed an opportunity to use Callan virus screen as sort of what it's intended for, a screen to tell us where we should be looking and to sort out so that we just aren't randomly sampling, but we have some targeted sampling, if that's a good tool.
Yeah, I think we actually did use Callan virus screen to target these populations. And I think we targeted them based on their score and tried to get a distribution where they had high Callan virus screen and lower ones. I also want to clarify that the results, the interpretation of this last bullet point is that participants with 90th percentile Callan virus screen they were in the 90th percentile category of the Callan virus screen data, had higher concentrations of air and dust. So I think the range was relatively higher compared to the other participants.
This is Stephanie, I can jump in. I'm pretty sure that with AB617 communities, they are using the Callan virus screen data to help identify those AB617 communities, which we are trying to focus on working with.
I actually have a question about the fall and winter months and the 1-NP metabolites being higher. It's somewhat surprising to me if it's traffic related and you'd think people would be in their houses more in the fall and winter. Do you have any thoughts about that?
I wonder if it's related to the inversion, the atmospheric inversion, and the higher concentration of these pollutants, and they just probably stay there lower. If that's
Any other comments, discussion, questions? It looks like we have one in, or several, I think, in the chat. I noticed.
I guess I can paraphrase unless ASAR's one wanted to get online, but so the design of EBDEP was to focus on parent-child pairs, and it sounds like what they had a choice, and it was usually the mom participated, although they did encourage the dads to participate if possible, but this was the end result of the recruitment. And then the kids, of course, were evenly balanced by gender.
Were there some other comments or questions in the chat? I thought I saw several. No?
We have Ken now. I will, an attendee, I'll allow you to talk. Please unmute yourself.
Thank you very much. One thing which we notice in Vallejo, the difference between winter month is because the wind direction change. Normally, we have south wind coming from southwest, and but during the winter we have the wind direction change from east to west, and that is because we are in a refinery community, and it depends on which direction the wind blow and also the location of the refinery. So that's one thing we notice the difference. Thank you.
Thank you, Ken.
Were there any other comments online or questions from the public? I don't see it right now, but no.
Maybe one phone.
Okay, Oliver.
Yeah, thank you for the responses to my question on sex and or gender inequalities. I do not find the responses acceptable. And there was a comment online here by chat saying, well, that is usual the case in family studies. Well, families, may consist also of male participants. And if I was to send a grant application to federal agencies, and I would say, well, I only take certain sexes into consideration, it would not be fundable. So I'm just saying that if that is the case, that family, studies are often imbalanced. I want to say, as a statistician or as a genomics expert, that is not acceptable, and then that has to change. Just to say to encourage is not an acceptable answer for the future, and we did talk about what to do in the future. When we think about, we want to look at all Californians, that does include men too.
Thank you. We still have time for open discussion. Whether any of the panel members have additional discussion about this presentation? Tenny.
I just wanted to comment to Oliver. I think it's a function of the study design of having a parent-child pair. And I've done various studies in low-income populations, and it's very common to have a family headed by a woman and a child, and that's who participates often. I don't know what the case in this particular thing. So I think it's more, I think your comment should go to how do we design studies that will capture both genders in the future. If you're doing a parent-child pair in a low-income population and you ask people to come forward, you will probably have a biased population unless you have made a decision ahead of time to exclude a bunch of people that want to participate and trying to oversample for other genders. But I think it's more a situation for future study designs.
Thank you. Nerissa?
I just wanted to make a comment that, this was obviously not the design of the study to exclude men, or if you are studying one particular sex, like we know we are doing in some studies, it just determines how you can generalize that data. And we are very aware of there are sex disparities in how people metabolize or are exposed to things. And so We take that into account in our analyses. But it's never the intent going into our studies to overly generalize out of a disparity, out of a disparate population. It is one of the realities of doing community work. And like we talked about with surveillance, you just have to be really careful with your protocols to make them accessible to people who are going to be able to get to your study site to participate in this. They need childcare, they need transportation. So it is one of the challenges of all biomonitoring studies.
Thank you. Actually, related to that, did you see any indication of sex differences in the children?
No, we didn't. We didn't look at it.
Thank you. All right, I'm looking to see if there's any additional comments or questions remotely or on the panel members. Not seeing any. Let's see, we have a little bit up. I do see something in the chat. And it just disappeared.
Did you want to unmute?
Yes, this is Swen Kaufman again from Biomonitoring California. And about the question of how much time was spent in possible differences in the seasons of time indoors versus outdoors, we do have hourly time activity diaries that people kept for themselves and the kids separately over the 4-day period of their participation each season, or each time, but for both sampling periods. So we could look at how much time, the difference in time spent indoors and outdoors during the different seasons.
Great, thank you. Yeah, I think that would be interesting to look at. Other comments, questions? All right. Thank you very much for the great presentation. And I guess we can move on to our next presentation. Let's see. Sorry. So our next speaker is Paramjit Behniwal, and she is a research scientist in the Environmental Health Laboratory, and she will give us an update today on the program's development of the laboratory methods for the analysis of VOC metabolites in urine. Paramjit.
Hi, good morning. My name is Paramjit Behniwal, and I work with the Biomonitoring program. So we developed a method for the VOC metabolites in urine using the LC-MS. And Jonathan Gallardo was our fellow, so he worked mostly on it. He just finished his fellowship with us and joined the PhD program in UC Berkeley. So what are the VOCs? They are the compounds which can vaporize at the room temperature, and they are mostly present inside and outside air, and then very common pollutants, and they are naturally found in the environment. They can also be released by the man-made sources like paints, cleaners, cigarette smoke, wood burning, etc., and also from the industrial processes. And they affect our health in different ways and in many ways. And like breathing, VOCs can irritate the eyes, nose, throat, and can cause difficulty in breathing, and can also damage our nervous system and other organs. And some of the VOCs, if we are exposed to them for a long time, they can even result into cancer. So what happens once when we breathe the VOCs, or they get into the system? So once they get into our system, they also do the reaction. There are damaging action, but also they get metabolized and get removed from the body through the urine, blood, and also breast milk and our breath. And mostly the metabolites are used as a biomarker for the VOC exposure because they are more stable and they reflect the recent exposure to the VOCs. And mostly they are excreted as mercapturic acid in the urine, and they have longer half-life than the VOC biomarkers in the blood. And Biomonitoring California, they do the assess exposure to VOC to check the disproportionality affected communities. And there are some studies that have been done already. And there's like a East Bay Diesel Exposure Program, Stockton Air Pollution Exposure Project, Fresca Biosphere. And there's an intra-program pilot project, IPP7, and the CFF California firefighters study. So here I'm just going to talk about a little bit the mechanism in the body, what happens once we absorb it. So it can be, there could be two things that go on at the same time. It can get metabolized to be more active compound, more toxic compound, and it can be directly metabolized to be excreted. So in the first one, like metabolism 1, and the cytochrome 450 chromosomes enzymes, they can oxygenase these, especially I'm showing the example for the acrylamide. So it can do the oxidation of the acrylamide and make into the glycidamide, which is more toxic to the body than the acrylamide itself. So once it gets more active, it can react with the DNA molecules and make it DNA adducts. And those DNA adducts then can damage our nerve endings and the nerves. So that's how they act as a neurotoxins. And they can also make adducts with the hemoglobins. And the other, and also through this process, they can also get detoxified with the glutathione conjugation and gets removed as the mercapturic acids. And the second, metabolism 2, instead of getting activated to the glycidamide, it can also just make conjugation with the glutathione and can get removed from the body into the different product. Like here it's the AAMA. Okay, so this is a little more chemistry or biochemistry in the body. So what happens, the RX is like our VOC compound. It gets attached to the cysteine of the glutathione. Glutathione has 3 amino acids: glutamic acid, cysteine, and glycine. So cysteine has a sulfur group where VOCs get attached, and then it makes a conjugation. And then the second step with the hydroxylation, glutamic acid gets removed with the help of the glutathione transferases enzymes. And then in the second step, then the glycine gets removed. So what is left is just the cysteine attached to the VOC compound. And then it can acylate it to make the mercapturic acid. Oh, wow. Can you fix it? Okay, maybe I can go back. Okay, thank you. So here I'm showing just all the parents' compounds that we are monitoring and all their metabolites with their full names and their short names. So how did we develop the method in the lab? So first we got the standards, each and every standard, and we made our solutions, and then we optimized our mass spec. So for the mass spec, we get all the molecular ions and optimized all the declustering potentials or the collision energy and choose the daughter ions. And then once we have the mass spec method, then we make the standard, combined standard, and then we optimize our LC conditions. So we throw, and then so that we get a good separation, the best possible separation that we can get. So we optimized all the solvents system and our gradient. So once we have the LC method optimized and the mass spec method optimized, then we go ahead and make our quality assurance, quality control samples that we do by getting, in this case, we did synthetic urine. So we made two pools of QC, one with the low level and one with the high level. And then we analyzed those QC samples over a period of sometimes, so we get at least 20 runs. So once we get the 20 runs, then we do the statistical evaluation, we get the coefficient coefficient of variation, and then we get the precision, the recovery and accuracy. And also we did the validation by getting some samples from the CDC. We get their PT samples. We got 4 samples from them. So, and we analyzed, those are 4 samples were of different concentrations. So we analyzed them and compared the results to how many we passed and what we did not pass. So here is our workflow, simple workflow. For in the step 1, we just dilute the sample. It's a dilute and shoot method. So we dilute our samples and standards to 1 to 10 in our mobile phase. And then this second picture just shows how we arrange them in our tray and then put it into the instrument. And the third step is shows our LC system. And the other one is the mass spec. So we have like a SciX mass spec. It's a triple quad, and we are using the ESI as a ionization for this one in the positive, in the negative mode. Keep pushing, sorry, keep pushing the wrong button.
Share it back.
I think I'm getting right there. Okay, thank you. Okay, so here are our conditions for the LC. So we have a SMART 2 Nexera LC, and using the Acuity HPLC HSST3 column, which is about 150 millimeter, and it's a 2.1 millimeter diameters. And our mobile phase is 15 millimolar ammonium acetate as a solvent 1, and acetonitrile is our solvent B. And then we have washes, strong wash and weaker wash to wash our needle in between the injections. And then we have the gradient for our, we start gradient from just 3% of the solvent B. Like it starts with very aqueous conditions, and then we go our organic solvent goes only up to 40%, and then it comes. So once it gets to 40%, we get almost all the compounds out. So here I'm listing our MRM transitions for all the compounds. And for most of the compounds, we have this different molecular ion and their daughter ions. But there are some compounds that they share the same molecular ion and the daughter ions. So that I have highlighted here, like our 2-MHA and the metabolites of xylene. All 3 metabolites, they share the same parent compounds and the daughter ion, but we are able to separate them by chromatography. So it's easy to quantitate them, even though they share the same compound. So another example is HPM2 and the CYMA. So they also share the molecular ion. So chromatography, we can separate, but if they are eluting very close to each other, then we can, then they have different molecular ions. So we have like 2-3 different parameters to consider to separate and quantitate these ions. One is our retention time and the molecular ion. Those are the 2 very important ones. So here I'm showing the chromatogram for all those compounds. So some of you see them that are very close to each other, but since we have different molecular ions and daughter ions, so we can still get a good quantitation. So here is our quality control from our low QC and high QC. It's from the 20 runs. most of the compounds, all of the compounds we get like coefficient of variation is below 20%. That's what we are saying. But majority of them are like below 15%, only few are like about 17%, which is on the high end. We are still trying to work out to bring it down. So see how we can improve the method. So like I already said that we got some reference samples from the CDC to validate our method. So there were 4 QA samples and 22 analytes out of the 24, they met the acceptance criteria. So there was AMCA and DHBM, which didn't meet the acceptance criteria. So AMCA is a metabolite of N-dimethyl formamide, and this didn't meet the acceptance criteria in all 4. So this one we failed, and it's usually on the higher side. For all of 4 samples, the result is on the higher side. So we know that something is not right with our standards. So we are trying to work out that. And DHBM failed in 3 samples. So we will look into that also. But there are some compounds that failed in only 1 sample. So that's like just a random error. So in conclusion, we kind of passed our validation with the CDC sample. So in conclusion, so we have a method for the measurement of VOC metabolites in urine. We can measure 25 compounds together, but 3 MHA and 4 MHA, they come together. So we can say we have a method for 24 analytes. And we get good accuracy and precision, which we demonstrated through the QC pools and CDC quality assessment samples. And we have analyzed the intra-program pilot project samples, which are 39 in number, and the campfire fighter studies samples, which is 66 in number. And we are reviewing the results. IPP study samples are with the QA at this time, and CFF study samples are, I'm still reviewing them. So, thank you.
Thank you very much for the presentation. We have time to start with clarifying questions from the panel members to begin with. Carl?
You, at the beginning, it's kind of your second slide, indicate that there are lots of sources of VOCs. They're everywhere.
Yeah, they are everywhere.
I'm wondering, does your data give you any indication about what major sources we ought to be paying attention to reduce them? Does this help at all in terms of the bigger public health issue?
I think it should, but that's not my decision to make. We just give the results to our.
I guess I was also thinking about the slide on the parent compounds, or their, you know, what are the sources and which are the parent compounds that contribute to them?
From the preliminary results from the IPP, we found that there's like, we are seeing the HPMA and the CEMA very high. So that is the products from the acrolein. So then we also have some high levels with the xylene. So there are some compounds which are a little, we see in almost all the samples, and some are very low, which is like only like few ppb, 3 ppb, 4 ppb. And also, so I don't know, because I'm not in part of the planning the studies, so maybe.
Yeah, I can answer that. So it's a good question, why, what do we do with all these lab results? And I think as Aalekhya has presented, there's a lot of profile analysis we can do to look at what the source might be, but also in conjunction with the questionnaires and the geographic analyses to try to pinpoint what are the really important sources that we can then target for reduction. But we can't do that work unless we have an available lab method. So we're really looking forward to using this analyses for.
Right, that seemed to be a good deal of pride in the procedures that have been developed for analyzing them. And I was trying to take it a step further. And what will this tell you about the bigger questions too that we have to worry about?
Well, I think we look forward to Biomosphere and Fresca and some of these other studies where we do have questions that are really specifically looking at filtration of air, for example, and being able to come up with recommendations for what that means in terms of reducing exposures, again, both on an individual level, what can you do in your own home, as well as on a policy basis.
Thank you.
And I have my hand up, but I'll call myself. This is Stephanie. I just wanted to add that, as Nerissa mentioned, yeah, we are excited to use these in our future studies, especially because actually EHL's panel is larger than the panel that we've had for at least say Pet Biosphere and Fresca. I think it more closely matches CDC's panel. And so we will have a few more chemicals included in our study, which will hopefully shed a bit more light on potential, different exposure sources. And again, to add on to what Nerissa was saying, we are trying to collect more environmental data to complement our biomonitoring data, which also might help elucidate some of those sources.
Thank you. Oliver, you had a question or comment?
Yeah, thank you. I am delighted to see analytical methods details. For those details, I saw that you do dilute and shoot 10-fold dilution. But usually when people look at urine, they do some normalization on the volume, either based on specific gravity or creatinine. Why don't you do that?
I think we will do the creatinine normalization.
But later, like afterwards, not beforehand. So often people do it beforehand to be sure that you're in the dynamic range, and I didn't see dynamic ranges here. I didn't see neat concentrations, so like without spiking, and I didn't see, some other measure of true positives in a way. And that comes to my second question. So these metabolites of the volatile organic carbons, of course, undergo multiple steps of enzyme control. And these multiple steps of enzyme controls can be different in different people. So, in one person with that exposure, might go more towards that route, and another person with the same exposure might go more to the other route. So that goes to the, are these really the right compounds, or you show different pathways that can be used. And so if we just look at one specific pathway, then we might miss the, differences, and the value we measure might not be a direct measure, or in this case, indirect measure of the true exposure. So what have you thought about that?
That's true, but we mostly followed the CDC method, and they have done a very thorough thought on it, that they picked up the most common or the most unique metabolites for that analyte, for that VOC parent. So like benzene has multiple metabolites, but this one, the one we are doing is like very specific. It doesn't come from other sources, but like other metabolites, they share many more parents. So then you cannot say that it's specific to the benzene. So these are very specific to these parents compounds. So if you measure that, then you can, with some certainty, you can say that, okay, this person is exposed to this particular compound.
I understand. Yes. I'm Jian Wenshe. I work with Dr. Behniwal. So I like your first question regarding to use some creatinine specificity measurement to guide the next step to decide how much dilution or we need to do the protein precipitation. That's a great idea. We didn't look at that, but we should look. And then also my comment on Carl's questions about the, how we can use this data to find out where the source comes from. Basically, for example, we did some study before this method, we look at the BTEX exposure. I use the BTEX exposure examples, so we can link our levels with a specific process. From that process, we measure, like, let's say BTEX is high, we know that most of the chemical come from BTS, or the alkaline level is higher. So we can try to attribute the source and the where the VOC come from. We can develop intervention or the prevention procedures. And that's the end on for what Amy said.
And I also want to add that, like you said about the dilution factor, it's if we our calibration range is very high for most of the compounds, the one that is more commonly found in the urine. But if it gets out of our calibration range, we are going to dilute the sample again and run it again.
A question or comment? Martha?
Thank you. Martha Sandy with OEHHA. To speak to Oliver's point that perhaps we have to look at the metabolites that are measured of a certain VOC and see if they're truly indicative of exposure to the parent compound. That is certainly a valid concern that we would look at that more closely because of genetic polymorphisms and other exposures that people may have that may alter their metabolic pathways for a certain parent compound. So that is something we are looking at. I believe the methods that were developed here are based on mercapturic acid metabolites.
Do we have any other questions from panel members or comments? Oliver?
So thank you again. So when you looked at the spiked examples, you used, I think, ATPBB, if I remember correctly. Was this value based on literature values? Like, did you expect this amount as a lower measure of quantification for typical urines, or where does it come from, the lowest amount of spiked values?
That depends on our instrument's capability, how low it can go.
So is it like, what do we expect? Is it the dynamic range covering what we usually expect in people?
Okay, so the low QC levels, yes. So we, based on the literature concentrations and also from the CDC, from their enhanced studies and then their publications and from other literatures. And we also usually try to keep our low QC levels to the lower end so that we can catch the lower levels, and the high QC levels are closer to between the middle and the high end of our calibration range.
Just have a quick technical question. Are there any specific concerns for how the samples are stored for measuring these metabolites, or?
Yes, they have to be kept in the cooler. If you take, at low levels, we store them at -80. So if you keep them in the refrigerator for long, then we lose some of the compounds because they are very unstable compounds.
So that's a concern for collection of the samples in the field too, obviously, I assume.
A few years ago, we worked with a collaborator, visitor scholar, and then we did a stability test. We did a long-term stability test, short-term stability test, stability post-preparation test, and also freezing the raw sound test, but only with the metabolite from the BTX metabolite, and which is benzene, toluene, xylene, and acid benzene. So we plan to do more stability tests. And during that test, we didn't find the problems. And when the sample stored at -80, and for long-term test, and we didn't find a freeze in the soil, we affect the analytical result. That seemed to be stable. But with 22 or 25 new analytes, we plan to do more tests. Yeah.
And to add on to that, well, I did run into problem in the beginning with my standards, because we were keeping them in the like -20 and taking them out every day, put them back into -20, take them again. So after 2 or 3 days, I start losing the peaks. So standards did get affected with the multiple timing, taking them out and putting them back.
Thank you. That's some very important information. Any other questions or comments from panel members or from anyone online? Stephanie or Rebecca? No.
Nothing online.
Okay. Great. Thank you so much for your presentation. Let's see. I think we're running a little early. If we have no additional discussion points now, do we want to take the break now or move on to?
Yeah,
a
let's
later
take the break now.
presentation? Okay. And we'll keep it at 1 hour as planned.
Let's just return at the usual so we can start a gum time. So I think that's 1:15. We'll ask everyone to return from lunch.
Okay. All right. Great. So everyone has a little bit longer lunch than planned. All right. Great. Thanks very much.